Should I start? Okay, good morning, consultants, senior registrars and registrars. Today's webinar is on the topic, discuss bacterial endophthalmitis, discuss the management of post-operative endophthalmitis. Okay, this is my outline. Introduction, the types of endophthalmitis, pathogenesis. Please, can you hear any echo? Hello?
Yes, there is echo.
Please, can we?
Let me put off.
Okay.
Do you have an earpiece?
And then you should put it on.
It's from my laptop. Let me put off my own.
Okay, Prof wants to put off his laptop. Okay, the types of endophthalmitis, pathogenesis, epidemiology, risk factors for bacterial endophthalmitis, then taking them one after the other, and differentials. Endophthalmitis is a purulent inflammation of the intraocular fluids, usually due to infection, which can be bacterial, viral, fungal, or parasitic. It's a serious inflammatory disorder resulting from infection of the vitreous cavity. It's a potentially devastating condition involving the internal structures of the eye, as well as the most feared complication of cataract surgery, which is the most common intraocular surgery done, and other intraocular surgeries. Progressive vitritis is the hallmark of any form of endophthalmitis, and histologically we'll see massive infiltration of the vitreous by inflammatory cells. From this, you can see that bacterial endophthalmitis is therefore a severe inflammation of the intraocular fluids by bacteria. Types of endophthalmitis can be based on the mode of entry, on the etiologic agent, or based on infectivity. Based on the mode of entry, it can be exogenous or endogenous. And
Dr. Chineke, please put it in slideshow.
Okay. Okay. On the exogenous, that's by direct inoculation of the organism from outside the body. It can be surgical or non-surgical. Under surgical, we have acute post-operative endophthalmitis, chronic post-operative endophthalmitis, filtering bleb-associated endophthalmitis, and endophthalmitis after intravitreal injection. Then under non-surgical, we have traumatic endophthalmitis. Pathogenesis, common causative organisms. For exogenous endophthalmitis, under it, which we have acute post-operative endophthalmitis, most isolates are gram-positive, 90% of them, and majority of them are non-coagulase staphylococcus, which Staph epidermidis falls under. Then we have Staph aureus strep species. Then we have gram-negative, which makes up 10% of isolates. For chronic post-operative endophthalmitis, it's caused mainly by Propionibacteria acnes, Staph epidermidis, and in some percentages, Candida. Filtering endophthalmitis, common causative organisms include strep species and Haemophilus influenza. For after intravitreal injection, endophthalmitis following intravitreal injection, we can have coagulase negative staphylococci. Traumatic endophthalmitis, we have Bacillus species, strep epidermidis, and strep species. And for endogenous, we have Bacillus cereus, which is the most commonly isolated one in IV abscess. We have other gram-positives and gram-negatives, which include Streptococcus species, Staph aureus, meningococci, and H. influenza. Under normal circumstances, the blood-ocular barrier provides a natural resistance against invading microorganisms. And when this barrier is breached, bacteria enter the eye, leading to release of cascade of inflammatory products, leading to inflammatory cell recruitment, release of digestive enzymes by the cells, and toxins by bacteria, leading to tissue destruction, and in most times, irreversible destruction of the photoreceptors, which even after the intraocular fluid has been rendered sterile continues. Any surgical procedure or ocular trauma that disrupts the integrity of the globe, like cataract surgery, glaucoma surgery, radial keratotomy, intravitreal injections, can lead to exogenous endophthalmitis. The source of infection for endophthalmitis cannot be identified with certainty. It's possibly from eyelid and conjunctival flora. Endophthalmitis vitrectomy study demonstrated that most isolates are from patients' conjunctival flora. Others are from contamination of sterilized instruments, disposable supplies, prepared solutions, surgical fields, or the intraocular lens, environmental air, surgeon, other operating room personnel. In endogenous endophthalmitis, blood-borne organisms permeate the blood-ocular barrier, either by direct invasion through septic emboli or by changes in the vascular endothelium caused by substrates released during the infection. Most cases of exogenous endophthalmitis, about 60%, occur after intraocular surgery, most times cataract surgery. In the US, the incidence of post-cataract endophthalmitis ranges from 0.1 to 0.3%. And following corneal transplant keratoplasty, approximately 0.2 to 0.7%, 0.029 per injection after intravitreal injections. A study here in Nigeria conducted by Ukwango et al., the incidence of post-traumatic endophthalmitis was highest, 68.8% and more in males, and that following cataract surgery, 0.07 to 0.32%, while that from intravitreal injection, 0.02 to 0.2%, and post-vitrectomy range from 0.039 to 0.07%. The figures here are higher in Nigeria because of diabetes and other comorbidities. And as I said before, because of also the trauma is highest cause of also traumatic, commonest cause of endophthalmitis here in our environment. An association appears to exist between development of exogenous endophthalmitis in cataract surgery and age greater than 85 years. Because as we advance in age, morbidity, comorbidities, and even ophthalmic morbidities like age-related macular degeneration, other things can also come into play. Endogenous endophthalmitis is rare, and its worldwide incidence ranges from 2 to 15%, and it occurs at any age. It occurs at any age with a mean age of 55 years, and the right eye is twice as prone for a focus of infection more than the left. Although in 25% of cases, it was found that it can be bilateral. The right eye, the explanation for the right eye being more prone is that because of the proximal and direct supply from the right carotid artery. Risk factors for bacterial endophthalmitis, we have the patient-related factors, eyelid abnormalities, xanthotrichiasis, pre-existing infections, blepharitis, conjunctivitis, canaliculitis, lacrimal duct obstruction, contact lens wear, infection of contralateral eye or sockets, immunosuppression, long-term topical antibiotic use. For surgeon-related risks, techniques such as clear corneal sutureless incision, temporal incision, prolonged procedure time, posterior capsule rupture with vitreous incarceration, wound abnormalities, wound leak first day post-op, poor theater etiquette in terms of gowning, scrubbing, gowning, wearing of face masks, passage of instruments, contamination of irrigation solutions, intraocular lenses, and even donor corneas. Intraocular lenses with propylene haptics are also known to have a relationship with endophthalmitis, maybe based on the properties, the surface properties. Also, drug-related, they have antimetabolite use, especially mitomycin C. Acute post-operative endophthalmitis, most patients present within 1 to 2 weeks, usually 3 to 5 days post-surgery, post-cataract surgery, and it refers to infectious endophthalmitis shortly after intraocular surgery. It is the most common form of endophthalmitis. Following cataract surgery has an incidence of 0.08% to 0.68%, and rates are increasing since clear corneal incision. Highest risks after intrasecondary intraocular implantation, and lowest after pars plana vitrectomy, because the vitreous can serve as a nidus for infection. So when after vitrectomy, the incidence is actually lower. Initial symptoms are rapidly progressive and include pain, red eye, ocular discharge, and blurring. Common signs include decreased visual acuity, lid swelling, conjunctival and corneal edema, anterior chamber cells and fibrin, hypopion, vitreous inflammation, retinitis, and blunting of red reflex. It's also worthy of note to note that retinal periphlebitis is an LS sign. Endophthalmitis vitrectomy studied only patients with acute endophthalmitis occurring within 6 weeks of cataract surgery or secondary IL implantation. And the symptoms they found out from the study that 94.3% reported blurring of vision, 82.1% red eye, 74% pain. Means almost 25% of patients can present without pain. That's 4.5% swollen lid. And signs include 85% hypopion. So 15% may present without having hypopion. 79% with hazy media and 26% light perception vision only. When there is a doubt between post-operative inflammation and endophthalmitis with severe haze in the ocular media or vitreous opacities clinically, the possibility of an infection should be given priority. Chronic post-operative endophthalmitis manifests several weeks or months after surgery, and is less common than the acute variety. Organisms isolated are less virulent. There are less virulent bacteria and fungi. Pain or discomfort may not be present, and inflammation can initially be steroid responsive but recurrent after steroid taper. Frank hypopion is often absent. Granulomatous uveitis with large precipitates on the cornea or intraocular lens can be seen, and is associated with white intracapsular plaque with Propionibacterium acnes. For filtering bleb associated endophthalmitis, it occurs as a result of pathogenic organisms gaining entry into intraocular tissue through conjunctival filtering bleb. The mean time between surgery and endophthalmitis range from 3 to 9 years, and incidence is 0.2 to 9.6% of glaucoma filtering procedures. There's increased incidence with the use of antifibrotic agents, which can cause thinning of the epithelium, leading to thin, cystic, avascular conjunctiva. Blebitis can also be associated with filtering bleb endophthalmitis, especially if there is no uveitis or vitritis. For endophthalmitis after intravitreal injection, increased use of these agents, the intravitreal agents, is of concern for risk in endophthalmitis. And like acute post-operative endophthalmitis, coagulase negative staphylococci is the most common cause. No infectious agent is actually identified in many cases. Triamcinolone acetonide crystals can migrate into the anterior chamber and mimic, hypopion. It accounts for 1.4% per injection in intravitreal triamcinolone acetonide, and accounts for 0.2% per injection for when ranibizumab is used. Intravitreal triamcinolone may also play a role in endophthalmitis potentiation. It is a steroid and the side effects of steroid, aftermath effects of steroid too. Traumatic endophthalmitis accounts for 25% approximately of endophthalmitis cases. After open globe injury, the chance of developing endophthalmitis is approximately 7%. Injuries, including intraocular foreign bodies, have higher rates. Other risk factors include dirty wound, lens capsule rupture, age greater than 50, delayed presentation of more than 24 hours after injury, and bacillus and staphylococcus are common in penetrating trauma with intraocular foreign body. It's important to rule out possibility of intraocular foreign body, removal of the foreign body, and primary repair as soon as possible. Endogenous endophthalmitis originates from sources within the body, mostly hematogenous, accounts for 2 to 8% of endophthalmitis cases. Patients usually have underlying diseases, history of recent intravenous infusion, diabetes mellitus, HIV, IV drug abuse, renal failure on dialysis, cardiac disease, malignancy, immunosuppressive therapy, or indwelling catheters. Liver abscess is the most common extraocular foci of infection, followed by pneumonia, endocarditis, and soft tissue infection. Cultures can be life-saving, and identification of organism is made by systemic culture of blood, urine, or CSF in 75 to 80% of cases. Patients are systemically unwell and mortality is relatively high, 5 to 10%. Prognosis for endogenous endophthalmitis is poorer than post-operative endophthalmitis and usually responds to systemic therapy alone. Differentials for bacterial endophthalmitis include occult retention of lens, cortex, or nucleus, hypopion, uveitis, inflammatory reactions to a drug, blebitis, keratitis, toxic anterior segment syndrome, fecal analytic glaucoma, phacomorphic glaucoma, vitreous hemorrhage, complicated or prolonged surgery, chronic or recurrent viral infection, usually for chronic postoperative endophthalmitis, a differential for that. Then management of post-operative endophthalmitis. As second part of the question, I said to draft another outline for it. Introduction, diagnosis, investigation, treatment, subsequent management, outcome and risk factors for poor outcome, complications of post-operative endophthalmitis, prognosis, then a short note on the endophthalmitis vitrectomy study. Post-operative endophthalmitis is a severe inflammation affecting the posterior segment of the eye following intraocular surgery and comprises of the following subtypes, as I mentioned before: acute post-operative, chronic post-operative, Pushing bleb associated endophthalmitis after intravitreal infections, and risk factors that can predispose pre-operative. You have diabetes mellitus, immunocompromise from other diseases, chronic blepharitis, infection of the lacrimal drainage system, contaminated eye drops, contact lens wear, contralateral or ocular prosthesis. We have application of xylocaine gel before povidone iodine. It's been found out that these anesthetic agents, when they are used, they decrease the sensitivity and decrease the sensitivity of the povidone iodine to microbial agents. Prolonged surgery or combined procedure, especially when example with vitrectomy, then secondary intraocular lens, posterior capsular rupture, when there is vitreous fluorescence, contamination of irrigation solution, clear cornea sutureless incision, temporal incision. For post-op, we have wound leak, vitreous incarceration, delaying post-operative antibiotics till the day after surgery. Management of post-operative endophthalmitis starts perioperatively through ophthalmic assessment, treatment of pre-existing infections, identification of comorbidities, and optimizing patients properly for surgery, and use of prophylactic antibiotic. Intraoperatively, good theater environment, clean and good layout, not facing a busy road, cut off from human traffic too. Theater walls, floors, and doors, non-porous and hard with minimal joints. no leaks from scrub areas, sinks, and water supply. Built-in electrical fittings with temperature 18 to 25 degrees centigrade, humidity 50 to 55%, ventilation control, AC with inbuilt filters, positive pressure compared to the outside, environmental decontamination and proper waste disposal, emptying linings frequently, good personal hygiene, trimming of nails by the personnel, no nail polish or jewelry, equipment covered and free of dust, adequate cleaning of instruments, especially the hollow bore ones, proper sterilization of instruments, AquaGuard water for scrubbing, rejection of instruments with poor cleaning, debris or deposits, rejection of fluids with particles, good surgical technique or reviewing and also reviewing of personal surgical practices, scrupulous preparation of surgical site, trimming of the eyelashes, good skin preparation, installation of povidone iodine 5% solution in the conjunctival furnaces on the stop for at least 3 minutes to allow for at least 3 minutes contact time, draping with proper isolation of the lead margin. Intracameral cefuroxime injected into the arterial chamber at the end of the surgery. Post-operative subconjunctival injection can achieve bactericidal levels in the arterial chamber for at least 1 to 2 hours. Then for post-operatively, we have use of newer generation of fluoroquinolones, which can penetrate the eye effectively to achieve minimal inhibitory concentrations. Surgical care for patients, for high-risk group patients, patients with surgical complication, elderly patients, and patients who had a prolonged surgical time. Early suturing of leaking wounds rather than observation. Diagnosis of postoperative endophthalmitis is essentially clinical and is critical to management. High index of suspicion should be maintained. A complete ocular and medical history is essential with thorough ophthalmic examination performed. You should suspect in any eye with inflammation greater than the usual postoperative course, searching for associations, wound leak or dehiscence, especially after small incision cataract surgery, vitreous incarceration in wound, eroding scleral sutures used to fixate intraocular lenses. You also in assessment, also search for septic foci, example suture abscess, and also rule out differentials. Presenting visual acuity is important in management. Comparing in the endophthalmitis refractomy study, comparing hand motion versus light perception. Usually, the standard is usually using the ETDRS chart for measuring the visual acuity, done at 4 meters. If patient can read at 4 meters, then at 1 meter, counting finger is done at 1 meter. Then if the patient still can't count finger at 1 meter, hand motion is done with a light source for the patient from behind, directed from behind the patient to examiner's hand, tested uniocularly 60 cm from the patient, and with the light source still moved upwards, downwards, and horizontally too. Out of the 5 times tested, if patient gets it right, the direction of movement of the light source, 4 out of the 5 times, you give the patient hand motion. But if not, then you go ahead to test for light perception at 90 centimeter using the indirect ophthalmoscope with the light at maximum intensity. Once clinical diagnosis has been made, endophthalmitis is an ophthalmic emergency. Patient is adequately counseled, admitted, and optimized. The patient is in pain, and analgesic is given. An investigation including ocular scan, especially if significant media opacity prevents adequate view of the fundus. Here, findings consistent with, we are searching for findings consistent with endophthalmitis, which include dispersed vitreous opacities with vitritis, choroidal thickening, and also to rule out choroidal or retinal detachment, intraocular foreign body, and dislocated lens material. Samples for microbial studies for gram stain culture and sensitivity should be obtained. Patient here is prepared as if going for intraocular surgery. Topical with subconjunctival, subtenon, or peribulbar anesthesia is administered. Povidone iodine 5% instilled. The eye is draped with insertion of elite speculum. Aqueous tap can be done. 0.1 to 0.2 mils of aqueous is aspirated through a limbal paracentesis with a 25 G needle attached to a tuberculin syringe. Vitreous tap, endophthalmitis vitrectomy study has found out that vitreous tap yields more positivity actually than the aqueous tap. A 1 or 2 mil syringe and a 23 G needle may be used, or a disposable vitrector measured with a caliper. While measuring with a caliper 3.5 millimeter from the limbus in a pseudophakic eye or 4 millimeter from the limbus in a phakic eye, 0.2 to 0.4 mils of vitreous is aspirated from mid-vitreous cavity. Conjunctival swabs can be taken, and in cases where the intraocular fluid use a negative culture, this can also, the result from the conjunctival swab can be used. And polymerase chain reaction can be used for unusual organisms. Also, when antibiotics has been for identification of organisms when antibiotic has been started, and in culture negative, to identify culture negative organisms. Systemic investigations can be done like fasting blood sugar. Treatments for bacterial endophthalmitis can be medical or surgical. Medical includes intravitreal antibiotics is the key to management, as levels above the minimum inhibitory concentration of most pathogens are achieved and maintained for days. They should be administered immediately after culture specimens have been obtained. Antibiotics commonly used in combination are ceftazidime, which covers for gram-negative organisms, including Pseudomonas aeruginosa, and vancomycin to address gram-positive organisms, including penicillin-resistant Staph aureus. Usually given as ceftazidime 2 mg in 0.1 ml plus vancomycin 2 mg in 0.1 ml. Alternatively, amikacin 0.4 mg in 0.1 ml can be used as an alternative to ceftazidime in patients with penicillin allergy. Subconjunctival antibiotic injection, vancomycin 50 mg and ceftazidime 125 mg can be used, or amikacin for patients allergic to penicillin. Topical antibiotics, usually given 4 to 6 times daily, can use vancomycin or ceftazidime. Also, third and fourth generation fluoroquinolones like mosifloxacin, levofloxacin can achieve effective concentration in aqueous and vitreous even in uninflamed eye. There's also room for use of oral antibiotics, mosifloxacin 400 mg daily for 10 days, or clarithromycin 500 mg daily. Oral steroids, they're used to limit destructive complication of the inflammatory process. Usually prednisolone 1 mg per kg is used with gastric protection in severe cases after 24 to 48 hours. That's after fungal infection, after ruling out fungal infection from examination of smears. Systemic antibiotics in endophthalmitis vitrectomy study, there was no difference in visual acuity or media clarity with or without IV antibiotics when given after intravitreal injection. So there's no, it does not really contribute too much. There's no aim to the treatment. Periocular steroids, they're used if systemic therapy is contraindicated. Dexamethasone and triamcinolone can be used. But topical steroids have dexamethasone 0.1% too early initially for anterior uveitis. Topical mediatic 0.1% atropine BD. There's also room for use of intravitreal steroids. It may reduce inflammation in short term, but do not affect final visual outcome. However, some studies have suggested a detrimental effect. Surgical management of post-operative endophthalmitis includes past planar vitrectomy, and if not immediately available, intravitreal steroids should be given as a temporizing measure. Advantages of past planar vitrectomy includes reduction of infecting organisms, toxins, inflammatory materials, and opacities, and it also allows for collection of sample. Disadvantages include the need for sophisticated instruments and operating room. vitrectomized eyes, they have a more rapid clearance of intravitreal antibiotics. In inflamed aphakic, a study done shows that in inflamed aphakic vitrectomized rabbits, intravitreal vancomycin and ceftazidime half-lives are 7.5 and 5.1 hours respectively, compared to 31.4 and 10.1 hours respectively in inflamed phakic non-vitrectomized rabbits. And in the endophthalmitis vitrectomy study, attempts were made to clear 50% or more of the vitreous. I should also know that for filtering bleb associated endophthalmitis, needle aspiration with bleb is not advised. Immediate pars plana comparison between immediate pars plana vitrectomy versus tap and inject. According to endophthalmitis vitrectomy study, no difference in final outcomes in patients who underwent initial tap or vitrectomy if presenting visual acuity was better than light perception. However, in patients presenting with light perception vision only, those who underwent initial vitrectomy were 3 times more likely to achieve 20/40 vision or better, and are twice as likely to maintain 20/100 vision or better, and had a nearly 50% reduction in the risk of severe vision loss compared to patients who underwent TAP. There was no difference, no long-term difference in media clarity between the 2 treatment groups. However, they conclude the challenge with this study was that the conclusion cannot be extrapolated for an endophthalmitis after other ocular surgeries like filtering bleb related endophthalmitis or chronic postoperative endophthalmitis. And also patients with no light perception, significant opacification of the anterior chamber were excluded in the study. So we don't know whether pars plana vitrectomy is superior in these circumstances. Subsequent management should proceed according to culture results and clinical response. Signs of improvement include contraction of fibrinous exudates, decrease in AC cellular activity, and hypopyon. An ultrasound scan may also be helpful in assessing the vitreous. If clinical signs are worsening after 48 hours, antibiotic sensitivity should be reviewed and therapy modified accordingly. Pars plana vitrectomy should be considered if not initially done. Intravitreal antibiotics can be repeated after 2 days, except with amikacin because it causes retinal toxicity. Based on consensus view, the endophthalmitis vitrectomy study protocol recommended reinjection if the infection was worsening at 36 to 60 hours after initial injection, and often 36 hours after treatment, culture results should be available. Repeat injection may increase risk of retinal toxicity, so decision to do this should not be taken lightly. We found that 100% the retinal toxicity rates with 3 intravitreal doses of 1 milligram vancomycin combined with 400 microgram amikacin or 200 microgram genticin in rabbit eyes. Patients with no culture, equivocal growth, or coagulase negative staph had a 5% rate of additional procedures, compared to 30% in patients with cultures that grew gram-negative or other gram-positive organisms. For chronic postoperative endophthalmitis, intravitreal antibiotics alone are unsuccessful. Therefore, removal of the capsular bag, residual cortex, and intraocular lens with secondary implantation at a later date may be considered. Outcome and risk factors for poor outcome is related to duration of infection prior to treatment and to the virulence of the organism. If the visual acuity at presentation is light perception, 30% to achieve 6/12 vision, but this doubles to 60% if visual acuity is better than light perception, according to the endophthalmitis vitrectomy study. An infection with Bacillus cereus and streptococci has a poor visual outcome despite aggressive and appropriate therapy, with 70 and 55% respectively, achieving a final visual outcome of 660 or less, which has been attributed to early retinopathy from the exotoxins. The most common cause of vision loss in the endophthalmitis vitrectomy study was attributed to macular abnormalities such as the epiretinal membrane, macular edema, pigmentary degeneration, and ischemia. Complications of post-operative endophthalmitis include persistent vitreous opacification, the aggressive and extended oral, topical, and or extended topical and oral steroid often lead to resolution. And if not resolving, you should consider vitrectomy. Macular complications as detected from the study. Hypotony. Here we should rule out wound leak, address persistent inflammation, and identify choroidal effusion and drain if necessary. Retinal detachment is another complication and may require vitrectomy. Others include chronic uveitis, secondary glaucoma, and otitis bulbi. Cases due to coagulase negative staphylococci, we are most likely to obtain 20/100 final visual acuity or better. Endophthalmitis caused by other gram-positive organisms such as Staph species or gram-negative organisms such as Pseudomonas has significantly worse final visual acuity. A short note on the endophthalmitis vitrectomy study, which was done between 1991 to 1994, it was the largest series of endophthalmitis study after cataract surgery, and 460 patients were used. It was a multi-center randomized prospective clinical trial. They used patients with clinical evidence of endophthalmitis within 6 weeks after cataract surgery or secondary intraocular lens implantation. Initial results were reported in 1995, and subsequent reports were published in the following years. The primary results revealed that patients with light perception vision fare better with initial plasplanar vitrectomy. When patients present with hand motion or better vision, equal visual acuity outcomes were achieved in the vitrectomy and vitreous tab groups. And there was no apparent benefit from the use of systemic antibiotics compared to control. Secondary results revealed that patients with diabetes mellitus and vision better than light perception achieved better visual outcomes with initial vitrectomy surgery, though not statistically significant. Additional procedures after initial treatments was found in 8% of patients who had their eye with vitrectomized eyes, and 13% who had TAP had additional procedures after initial treatment. There was no statistical difference between vitrectomy and TAP groups in terms of microbiological yield, operative complications, retinal detachment, or visual acuity outcomes. And based on current evidence, there is a low incidence of post-cataract surgery endophthalmitis, and is variable 0.03% to 0.15%. Povidone iodine prophylaxis is generally recommended for cataract surgery, and also intracameral antibiotic prophylaxis is recommended. And this is my bibliography. Thank you.
Dr. Shizuke, well done. I want to congratulate you for being able to make this presentation. Despite the initial challenges we had with network and even the screen resolution. I'm happy that eventually you are able to make the presentation. I observed too that your slides were non-number. Was it deliberate? How many slides did you have?
41, sir.
Okay, so why
41.
were they not known? Okay.
Aye.
All right, so I think we'll give room to the residents now to comment or ask questions. Following the usual rule, you raise up your hand and then the host will identify you. And then after that, the consultants can make their comment. Thank you very much.
Margaret.
Okay, good morning, everybody. Good morning, consultants. Good morning, senior colleagues. Good morning, my
Dr. Afam, are you still there? We can't hear you.
Okay, Dr. Damta.
Okay, good morning. Thank you, Dr. Chijoke, for this presentation. I want to highlight what would be your treatment option, comparing the fact that post-operative endophthalmitis can occur in the risk can occur in cataract surgery as well as in post vitrectomy or vitreous stab. And we know that the mainstay of our treatment most of the time is intravitreal injection.
So I can't hear you well. You know that what?
The mainstay of our treatment for post-operative endophthalmitis is intravitreal injection. So how do you rate the risks from the cataract surgery and the intravitreal injection? Do you stop the treatment because it also carries a risk? Or how do you now relate the two? I don't know if my question is understood.
No.
Okay, knowing the fact that maybe a cataract surgery also carries risks for post-operative endophthalmitis,
Yes.
as well as intravitreal injection.